craniovertebral junction, because we are standing human position and the muscles of the craniovertebral junction become weak and the odontoid process goes up. And this goes up because of an unstable craniovertebral junction. So basilar invagination is a problem of weakness or instability of the muscles of the craniovertebral junction, and the odontoid process goes up. And as I was talking to you the other day, we had introduced this concept that open the facetal joint and distract the facet, distraction of the facet, and reduce the craniovertebral junction, basilar invagination. So this is the technique we had described. So this is basilar invagination. You open, this is due to weakness of the muscles. So but first concept that I want to give you is that the weakness of the muscles is the bottom line of the problems of craniovertebral junction. There is no problem with the bones, no problem with the anti-arch, no problem with the odontoid process. Problem is with the muscles. Because of the standing human position, the muscles become weak and the odontoid process goes inside, and this is the treatment. There is no need for decompression. There is no need for anterior decompression. There is no need for posterior decompression, because there is no problem with the bones, no problem with the odontoid process. The problem is the muscles. And when they become weak, this area becomes unstable and it needs stabilization. It does not need decompression, either from front or from behind. So basilar invagination, long time ago we said that this is C1, C2 facet. The facet of C1 comes in front, and there is listhesis of facet of C1 over C2, like lumbosacral listhesis. And this is due to the weakness of the muscles. There is no problem with the bone, no problem with the bone. Muscles become weak, and there is listhesis of C1 over C2 and results in basilar invagination, like lumbosacral listhesis. So we had introduced this beautiful concept that basilar invagination is nothing but C1 over C2 listhesis. Listhesis is due to weakness, and the treatment of weakness is stabilization. Because of the standing human position, there is a vertical dislocation. Vertical, you see, in flexion it goes up, and in extension it comes down. You see, flexion goes up, extension comes down. So there is no atlantodental interval disturbance, but there is a piston-like, piston up and down movement due to the weakness of the muscles and the incompetence at the facetal articulation. It leads to vertical mobile dislocation. You see, this is an extension, the odontoid process is down, and in flexion it goes up. So there is a vertical due to the weakness of the muscles and due to standing human position. So basilar invagination is nothing but an unstable craniovertebral junction. It does not need decompression. It does not need decompression. It needs stabilization. So this is the concept that we introduced in this subject of craniovertebral junction, that do not remove odontoid process. Do not remove foramen magnum bone. You have to fuse. You have to stabilize. This is an unstable situation, and stabilization is the treatment. So this is the concept, that instability is the problem and stabilization is the treatment. No decompression, and decompression is wrong. Like in this situation, there is an unstable craniovertebral junction. Do not remove this. Do not remove this. Stabilize it. Even if there is a malalignment, no problem, but stabilization is the answer to this problem. You see this case, there is basilar invagination, there is Chiari malformation, there is syringomyelia. I am going to discuss about syringomyelia in my next lecture. So total, I have decided to give you 5 lectures, and you can, if you do not like, you can stop me after 1 or 2 or whenever. But today is one introduction. Tomorrow, I want to give you the concept of central or axial atlantoaxial instability and Chiari malformation and syringomyelia. Day after tomorrow, I want to give you next topic number 3 will be degenerative spine, which I will introduce to you today. So there is a facetal instability. You see there is a facetal instability due to the weakness of muscles, and this does not need decompression. There is no need for foramen magnum decompression. There is no need for syringostomy. There is a need for stabilization. There is no need for decompression. So that is the basis of my concept. Now I want to discuss with you the facts of the facets of the craniovertebral junction and of the rest of the spine. So the facets of C1 are round and horizontal and flat. And this is the most mobile joint of the body. And I have to give you one statement now that atlantoaxial instability is the most common spinal instability. Atlantoaxial instability is the most under-recognized clinical entity in our subject of neurosurgery. Atlantoaxial instability is the most under-treated entity in our subject. I want to discuss with you these concepts in my lectures. Before I go, I want to just tell you about the disc. Intervertebral disc is a very fantastic material. It is a divine material. It is a God material sent by God. So this was one of my articles I wish you can read. So what I am saying is reverie. Reverie means prayer. Prayer. You pray to God. Intervertebral disc is a God-made structure. You see, this is an astronaut in the space and he's flying. Similarly, this is a fetus in the amniotic fluid. And the fetus is, no matter how heavy the fetus becomes, it floats in the amniotic fluid and it is weightless. That is why a pregnant woman can run even with a 3 kilo or 3.5 kilo baby, because the amniotic fluid makes the baby weightless, because the baby floats in the amniotic fluid. Similarly, the CSF, this is the CSF, the brain is 1.5 kilograms, but it is weightless. Why it is weightless? Because it floats in the CSF. So this was my first beautiful contribution in neurosurgery, that the main function of CSF and the blood in the skull base, the fluids have a role to make the brain weightless. So the function of fluids is to make the body weightless. Similarly, when we stand, we do not stand bone over the bone. There is some fluid in the knee joint. So there is, every joint has a fluid. So when we stand, if I am 80 kilograms, I'm not feeling my weight because we are weightless, because the fluids keep us floating. If the bones touch the bone, then it pains and then we need to give treatment. Basically, the function of the fluid is to move, provide movement, provide stability, and more important, it provides weightlessness. That is very important function of the fluids. So this is the joint intervertebral disc of the snake. You see, this is a ball and socket joint. and there is a very big movement in the snake's vertebra. This is a millipede. This is an invertebrate animal. There is lot of movement. There is no bone in this animal, but there is lot of movement. So my concept is bones do not provide movements. Movements are provided by the liquids or fluids or the disc. This is a cat. The disc space is small, the bone is long. That is why there is a catwalk when you are having, like in the model show. Catwalks, the movements of the spine is not so much. Movements of the hip joint is too much. So catwalk means the spine does not move. So all these movements of this lady are due to the disc, the mobility, the shape of the spine, the weightlessness. You see the lady can on one toe, the whole body, because the whole body everywhere there is fluid. Fluid, and the disc is one very important fluid. I want to ask the question to all of you. In this big aircraft, which is the strongest part of the aircraft? Answer this question. Whether it is the nose of the aircraft which is the strongest, whether it is the wings of the aircraft which is strongest, whether it is the tail which is the strongest. Now let me answer this question for you. The strongest part of the aircraft is these tires. And when the plane lands on the tire, which is, and some oil in the here in the gears, this oil and this fluid is the strongest part of the aircraft. If the plane lands on the nose, it will be shattered into pieces. If the plane lands on the wings, it will be shattered into pieces. It has to land on the wheels. Like your car, if your car is not full of in the car tires, if they are not having air, the car will not be able to run for even few meters. So that air in the car is like a disc. So disc is a very important structure. This has two parts. One is the annulus fibrosus and one is the nucleus pulposus. And you must read my articles on this subject, that these are ball in ball joints. And these very beautiful contribution by one of my very great teachers on this subject, that this is divine. Disc is divine, okay? Disc cannot go wrong. This is my concept, and we have to pray the disc. If you read the entire literature on spinal spondylosis, the whole literature is disc-centric. It means when you read the article on cervical spondylosis, the first sentence of the article is, disc degeneration is the beginning of spinal spondylosis. This is the sentence. Disc space reduction, disc space degeneration, and age-related disc problem is the center of the problem of cervical or lumbar degeneration. This is the concept. And my dear friends, I am introducing to you a different concept. I am saying this concept is wrong. And I want to introduce to you another concept. My concept is, you see, this is the body and this is the, you see, this is the piston. This is the center of movements. And this movement is at the facet joint, facets. You see these huge muscles in the back. All these muscles are active on the facets. If you see the disc, there is only one longus colli muscle, which is very thin. There are no muscles attached in this region, or a very thin layer of muscles. So the activity is not here, the entire activity is behind by these big muscles. So the center of activity is not the disc, it is the facets. And this is the key point of my discussion today, that the facets, the weakness of these muscles lead to problems in the facets, and the problem in the facets is the beginning of spinal degeneration. You see these huge muscles, all the muscles are behind and all the muscles are acting on the facets. In front of the thoracic spine, there is no muscle, there is abdominal content. In the chest, there is lungs and there is heart. Here, there is trachea and esophagus. No muscles, no activity occurs from the front. All the activity comes from behind, and weakness of these muscles is the beginning of spinal degeneration. This is my concept. Facets are the problem. Facet is the site of activity of all muscles, and facetal weakness is the problem in the entire spine. And this problem is visible in the craniovertebral junction because of the alignment. You see the alignment? The facets become like this, facets become like this, and the facetal instability is the issue. And facetal stabilization, you stabilize the facets, that is the treatment. So we introduced this technique of C1, C2 fixation of the facets. And as you know, this technique is biomechanically the strongest because the facetal bones are the strongest bones of the body. Transverse process is the biggest transverse process of the atlas. C2 spinous process is the biggest spinous process of the bone, of the entire spine, and the facetal bones are the strongest bones of the entire body. They are of the strength of a tooth. Now I want to show you some beautiful, now you please pay very strong attention to this concept which I am introducing to you. You see there is this bulging in front of the spinal craniovertebral junction. Several years ago, not several, about 15 years ago, this was called pseudo-tumor of the craniovertebral junction. And the whole world, the treatment was to come from transoral surgery and remove this pseudo-tumor. Then somebody said, no, not come from front, come from side. So we introduced a very fantastic and a revolutionary concept that this is not a tumor, this is like an osteophyte. This is osteocartilaginous in structure, this is osteophyte, and this is not a primary problem. This is related to atlantoaxial instability, and atlantoaxial stabilization is the treatment. There is no need to remove this osteophyte. So we call this pseudotumor as osteophyte, and subsequently, you know, those who are in this craniovertebral junction know that many people now do atlantoaxial stabilization for this, and no need to remove this osteophyte. So for the first time in the literature, we said in the year 2004 that atlantoaxial instability is the cause of this retroodontoid osteophyte, and atlantoaxial stabilization is the treatment. There is no need to remove this osteophyte. Then came our very beautiful another article. You see retroodontoid cyst. This is not actually a cyst. This is also called a pseudotumor. You see pseudotumor, retroodontoid pseudotumor. And if you realize that the whole world will come from either from the mouth or from behind because there is a lot of cord compression. So we introduced this concept that this pseudotumor, this behind the odontoid process, is an evidence of atlantoaxial instability. You stabilize the joint and this retroodontoid tissue can disappear in the immediate postoperative disappearance of the retroodontoid tumor. No removal of the cyst, no removal of the cyst or of the tumor. So this what we said, that this is a manifestation of atlantoaxial instability. When we see this, we should not jump and remove this. When we see this compression, we should not start decompressing. So I introduced the concept that there is no need for decompression in this entity. There is a need for atlantoaxial stabilization. Similarly, this huge cyst, but there is an unstable atlantoaxial joint. There is an os odontoideum. This is the retroodontoid pseudotumor. I did stabilization, and you see the cyst is gone, and you see there is no compression in the craniovertebral junction. What I mean to say, that we should recognize atlantoaxial instability, and we should recognize the secondary consequences of an unstable joint. This is another case where there is os odontoideum, which is an unstable atlantoaxial joint. As you know, this is a retroodontoid cystic formation. This does not need removal of this cyst. It needs stabilization, and the cyst will disappear. So this is one concept. Now I want to show you another beautiful concept. You see this bone formation, this is not os odontoideum, this is apical ligament ossification. You see this ossification around the facetal articulation. This is not congenital problem, but this is due to atlantoaxial instability. When you see these ossifications in the facetal articulation, around the facetal articulation in front of the odontoid process, this is not, there is no need to remove this. There is no need to do decompression. What you need to do is realignment and stabilization, and this, there is a need for stabilization. So instability is the problem and stabilization is the treatment. Another very fantastic concept that we introduced is about rheumatoid arthritis. Rheumatoid arthritis, we all know that there is a pannus. So the whole world used to come transoral and used to remove the pannus, and the concept was there is a compression of the cord here, and this pannus is causing the compression. So we introduced the concept that this pannus is a secondary to buckling of the posterior longitudinal ligament due to vertical instability of the atlantoaxial joint. So this is the unstable joint. So we introduced an intra-articular spacer. So we distracted it and brought it back into shape. And this was the buckled posterior longitudinal ligament, and this buckling was straightened, and you see immediate postoperative regression of retroodontoid pannus after lateral mass reconstruction. The concept is that this is not the problem. This is a secondary phenomena to atlantoaxial instability. So there is no need to do decompression from here. There is no need to do decompression here. There is a problem of instability, and these are secondary features. These are due to buckling of the ligaments, and this is distraction reduction is the treatment. You do introduce these facetal spacers, and you do distraction reduction and fixation. In rheumatoid arthritis, the facetal becomes weak, and there is quite a significant basilar invagination. So we introduced this concept that realignment of the craniovertebral junction is the treatment. There is no need for decompression. So there is no need to remove this odontoid process, and there is no need to remove this foramen magnum bone. What is required is craniovertebral junction realignment for the treatment of rheumatoid arthritis. So this was the first time in the literature where such form of treatment was introduced for rheumatoid arthritis of the craniovertebral junction where there is no decompression. So we introduced these intra-articular spacers and we introduced the concept that you can distract and reduce and stabilize, and you see this bone fusion. So we call this concept as joint jamming technique, intra-articular spacer fixation technique. So as I mentioned, the entire subject of degenerative spine is dyscentric. The subject of facets has never been studied, and I have challenged this concept that the disc is the problem. My concept is that the muscles are a problem and weakness that is manifested at the facet is the issue. Craniovertebral junction instability has never been studied. And this was my article in the year 2010, where I studied craniovertebral junction and presented my work in 108 cases. And I introduced several revolutionary concepts in the craniovertebral instability due to degenerative osteoarthritis. Like you see, the bone formation here is an osteophyte which is secondary. So we introduced the concept that craniovertebral junction instability manifested at the atlantoaxial joint causes degenerative osteoarthritis. Now you carefully, my dear friends, carefully look at these slides, carefully. Atlantoaxial instability causes reduction in the joint space. You see there is reduction in the joint space. It causes osteophyte formation. It causes buckling of the posterior longitudinal ligament. You do not have to come and remove these osteophytes. You do not have to come and remove these buckling ligaments, which will ultimately form the osteophytes. And in some situations, it may form a pseudotumor. What is required is atlantoaxial stabilization. This bone formation here is not a primary process, it is a manifestation. You see the bone formation here, the bone formation here, the bone formation here, the bone formation here, the bone formation here. This bone formation, you do not have to come and decompress. There is no need to do decompression. The treatment is craniovertebral junction realignment and stabilization. That is the treatment. Here is another bone formation in the region of apical ligament. There is some bone formation here. This is not a primary process. This is a secondary phenomena, secondary to atlantoaxial instability, and stabilization is the treatment. There is no need for decompression. This is another case. You see the osteophytes here, the bone formation here. There is osteophyte formation here, osteophyte formation here. The joint space is reduced. You see the joint space reduced. This patient does not need reduction. This patient does not need any decompression. This patient needs realignment and stabilization. This is another case. You see some bone formation here, and there is a problem here. This patient needs stabilization. This is another case. You see there is a joint problem. You see the joint is eroding. There are abnormal bone formation around the apical ligament. You do not do decompression. You do not do decompression. You do realignment and stabilization. That is the treatment. So my dear friends, I want to introduce to you a beautiful concept. And you please have a look at these slides. What I'm trying to show is you see reduction in the disc space, bulging of the disc here, osteophyte formation here, multi-level osteophyte formation here. My concept is there is no problem with the disc space. There is no problem with the osteophytes. These are the manifestations of an unstable spine, and this spine needs stabilization. You see, when you do dynamic picture, there is no instability, but presence of osteophytes is an indicator of an unstable spine. So when you see these osteophytes, there is no question that this is not the disc is not the problem. Osteophyte is not the problem. Problem is the weakness of the muscles and a vertical instability at the facetal articulation. So this is a very wrong image that has been introduced, that there is a problem with the disc and there is nothing here. So this is not the issue. So I want to introduce to you, my dear friends, a very fantastic new revolution in spine surgery. And today I will give you some brief introduction, and tomorrow I will expand on this. Not tomorrow, in my part 2 lecture, I will give you different concepts. I want to give you 5 lectures on this spinal revolution. I am sure you will enjoy it. And if you are not enjoying, you can stop my lectures. That depends on you and your esteemed, wonderful society. So I am giving you a concept that spinal degeneration, the genesis of the degeneration is in the vertical facetal instability, not at the disc. Instability at the facetal articulation due to the weakness of the muscles is the point of genesis of the spinal spondylotic disease. So we introduced these spacers inside the facetal articulation and stabilized the facetal joint without doing any decompression. So this is, for today, I'm giving you this concept. Tomorrow, I will give you another. So today, what I'm showing you is that facets are the problem, reduction in the joint space and facetal listhesis is the issue. Vertical facetal instability is the point of genesis of spondylosis. Osteophyte formation is a secondary phenomena. Ligamentous flavum buckling is due to the vertical spinal reduction in the height of the spinal column. And facetal distraction is the treatment. You see, we can see very clearly the facets of C1 and C2, but the facets of the cervical spine and lumbar spine has never been really studied in the literature. As I mentioned to you, all the muscles are concentrated on the facetal articulation, and when they become weak, there is a listhesis of facets, and when there is a listhesis of the facets, there is a vertical reduction in the height of the spinal column, and it results in the buckling of the posterior longitudinal ligament and buckling of the ligamentum flavum and reduction in the height of the disc. And we introduced these facet distraction spacers, which I called Goel facet spacers. In the year 2010, this article was published. And little bit I want to elaborate on this in my present lecture, but I will elaborate further in my subsequent lectures on this subject. So facetal distraction spacers as the treatment of degenerative spine as a new hypothesis of treatment of spinal degeneration. facetal distraction arthrodesis technique, can it revolutionize spinal stabilization methods? So I am saying yes, it can revolutionize the spinal stabilization method, and this technique we have labeled as Goel facetal distraction arthrodesis technique. And this was published in Journal of Neurosurgery in the year 2011, facetal distraction as a treatment for single and multi-level cervical spondylotic radiculopathy and myelopathy. A preliminary report, this was published in the year 2011 on the basis of my experience, and this was published as a cover page of the Journal of Neurosurgery. So I wish, my dear friends, you please read this article, which I want to now discuss with you. If you hold the spine in your hand, the facets are oblique like this. In the cervical spine and in the lumbar spine, they are almost parallel, like in a straight line. If you hold the vertebra, this is the strongest part of the bone. This is the weakest part of the bone. This is the weakest part of the bone. The strongest part of the bone is this facets. And the facetal articulation listhesis due to this oblique alignment, there is listhesis of the facets, which is the beginning of spinal degeneration. So we had made several studies on this subject of the morphometric analysis and various kinds of quantitative analysis of lumbar spine, of the cervical spine, and we had introduced Goel facet spacers, and this facet distraction technique we had introduced. You see, there is this facetal articulation is quite strong, and this is located laterally, and you cannot see this on the MRI because this is not near the neural structures. What you see is the buckled posterior longitudinal ligament and the buckled ligamentum flavum. So we introduced this very fantastic concept that osteophyte is not the issue. Buckled ligamentum flavum is not the issue. Unstable listhesis is the issue. You see the listhesis of the spine, which cannot be recognized in general, but if you see carefully, beautiful images. Now I want to show you several images. You see here, there is a big osteophyte. There is reduction in the joint space. There is osteophyte and compression. There is ligamentum flavum buckling. So if you read the literature, this is called osteophyte is the problem, and this is the problem, and this ligamentum flavum is hypertrophied and problem or pathological. We said there is no problem with the ligamentum flavum. There is no problem with the disc. There is no problem with the osteophyte. You distract the facet and stabilize the facet, and the osteophyte will disappear. The ligamentum flavum will become unbuckled. You see the ligamentum flavum buckling. And the disc, you see there is white. The disc space has, there is a nude fluid in the disc space. So the treatment is no removal of the bones, no removal of the disc, no removal of the osteophyte, no removal of the lamina, no removal of the ligamentum flavum, no removal of anything. There is no need for any decompression. There is a need for stabilization in a distracted position, and this is an immediate postoperative recovery in the symptoms. Now you see this patient. There is a big osteophyte here, and there is a compression of the cord. There is reduction in the joint space. There is reduction in the joint space. And we have introduced these spacers in this joint and this joint. You see there is a spacer here and spacer here. There is a spacer here and spacer here. And you see there is a new disc formation, and the posterior osteophyte is disappeared. The ligamentum flavum is disappeared, and there is no bone decompression, there is no anterior surgery, and you are seeing a new disc. Ultimately, because we have fused, it will ultimately result in arthrodesis of the spinal segment. Now you see there is a multi-level disc issue here, multi-level disc space reduction and osteophytes at various levels. There is reduction in the facetal articulation space, and you see we have introduced spacers in multiple spinal levels. You see the spacer here, spacer, spacer. And if you carefully see this image, the osteophyte, this is immediate postoperative situation. The osteophytes have reduced, and there will be ultimate fusion in this treated segment, and there is no decompression from the front, and there is no decompression from behind. Now you see this another beautiful case. You see this large osteophytic protrusion here. You see there is a large osteophytic protrusion, and you see this protrusion is disappeared after, this is I think after 1 year scanning, and you see the fusion of this vertebrae here. There is fusion at multi-level fusion. Now which levels to fuse I will discuss in my next lecture with you. I am going to, as I mentioned to you, I am going to give you 5 lectures. Today is part 1. I want to just introduce this concept to you, that there is no need for decompression. There is no need for decompression from front. There is no need for anterior surgery and discoidectomy and osteophyte removal. This will disappear very soon. And the problem is an unstable spine. Disc is a divine structure. This is not the issue. Stabilization is the treatment. And you see the movements of the neck are quite well preserved. So intrafacetal, intra-articular spaces is a concept, is an emerging concept, and that's, I want to show you several images of this concept. This is another case similar to the previous one, multi-level spinal degeneration. I also want to discuss with you the issue of OPLL in the subsequent lecture. That will be in lecture number 4, the issue of OPLL. But you see here, there are 4-level intrafacetal spacers have been introduced. It increases the disc height, it increases the intervertebral canal height, it increases the intervertebral disc space height, and it increases the spinal canal height, and there is no need for any decompression from front or from behind. Stabilization is the treatment. You see another case, there is a big osteophyte here, and there is quite a bit of cord compression. I introduced, you see there is a reduction in the joint space. I introduced these spacers in the joint cavity, and you see there is a spacer here. And if you see, this one is preoperative and postoperative, you see there is white in the disc space. The osteophyte has reduced and the ligamentum flavum has stretched. And I have to tell you that this patient, remarkable improvement in clinical status. This is another case of large posterior osteophyte or disc herniation kind of situation. I did multi-level stabilization with facetal spacers, and you see the disc has gone, and there is multi-levels. There is no decompression from front or behind. You see the disc, the facetal articulation space has increased. You see the space here in this picture, and you see the space in this picture, it has increased. Basically, it has increased the root canal diameter, and there is no compression in the spinal canal. This is another beautiful case. You carefully see this case. You see here, this is the degenerative spine. This is the facetal articulation. And after 1.5 years, you see after there is a fusion of the whole area. And this is a fusion of the facetal articulation. You see bone arthrodesis. This is preoperative. You see there is listhesis of the facets, and there is stabilization of the facet and arthrodesis. And there is preservation of the neck movement. This is another beautiful case for you. You see, this is introduction of the spacers in the joint cavity. And you see the fusion, the bone fusion. This is the problem situation. There is introduction of an increase in the interlaminar height. There is no decompression of any kind from front or behind. There is no decompression. And you see, ultimately, the whole thing stabilizes and fuses. I know many of you must be confused with what I'm saying, but I promise you in my subsequent lectures, I will clarify this concept much better. Today is just an introduction. You please enjoy it. Multi-level disc bulges are not due to osteophyte formation, but due to buckled posterior longitudinal ligament, which initiates a process of bone formation or osteophyte formation. This is ligamentum flavum buckling. Do not touch this. This is a secondary problem. It indicates multi-level spinal instability. It needs multi-level stabilization. You see, after 2 years, there is no problem. This is a normal spine. And you see all these osteophytes are disappeared. There is a new disc formation. Ultimately, of course, this will all fuse. This is the same scan, same patient, and you see multi-level problems, and you see the fusion after 2 years. And there is no decompression from front and no decompression. So my concept is instability is the problem and stabilization is the treatment. This is another case. You see, there are osteophytes at multiple levels. After 6 months, this is the situation. You see the fusion. You see the facetal spacers at multiple spinal levels. And you see the fusion here. And you see the multi-level spacers and fusion. And there is no decompression. And this patient, remarkable clinical improvement. Now, you see, I will answer another question. You see, decompression is very easy for me. When I am doing facetal fixation, I can easily remove the lamina. What is the problem? But it is not necessary. That is why I do not remove. What is the problem if I come and remove the lamina? I say decompression, decompression. I am saying decompression and removal of the bone is a negative phenomena. This patient needs stabilization. Like I told you in craniovertebral junction, there is no need to remove the bones. There is a need for stabilization. Similar concept in this situation. There is no need to remove the bones. There is a need for stabilization. This is another beautiful patient, multi-level osteophyte formation and ligamentum flavum buckling. The whole world will come from here, do corpectomy and do corpectomy and do discoidectomy and do osteophyte removal. I say those things are not necessary. There is a revolution in spine surgery. And I want to introduce this revolution to all of you. You see, there is a new disc formation here. The ligamentum flavum is disappeared. The osteophytes are disappeared after 1 month of surgery. And this is a new patient. This is another case with multi-level osteophytes. The whole world will say, I will come and remove this osteophyte from here, remove this discoidectomy, I will do corpectomy. And you will say, if he says some nice English, I will do corpectomy, you will say, very good, very good. But if I say from India, I will not do corpectomy, you may not believe it. But I will give you this information, my dear friends. You have invited me to your forum. You see this patient, no removal of osteophytes. The whole osteophytes are disappeared, and ultimately there is intrafacetal spacer introduction and fixation. There is no decompression. Decompression is not the treatment. Stabilization and arthrodesis is the treatment for degenerative spine. This is another case. You see large osteophyte. The whole world will come and remove this osteophyte. They say compression, compression, compression. There is no problem of compression. You see, this is post-operative. This is intra-articular spacer introduction, and the compression is gone. There is increase in the interfacetal space. There is an increase in the intervertebral foraminal height. there is an increase in the disc space height, and there is a fusion. There is no need for any kind of decompression. You see, there is no laminar removal, no spinous process removal. I could have easily removed this. And I could have easily come and remove this and remove this, but that is not the treatment. This is not the problem. This is ligamentum flavum is not the problem. The solution is stabilization. This is another case where there is a stabilization, and you see there is reduction in the osteophyte formation. This is another beautiful case for you. You please carefully look here. There is multi-level disc bulges and there is multi-level ligamentum flavum buckling here. The whole world will say, I will do laminectomy, or I will do laminoplasty, or some people will say, I will do multi-level corpectomy and osteotomy and all those things. But this patient, you see, this is post-operative. All these osteophytes are disappeared. All this bulging ligamentum flavum is disappeared. You see multi-level interfacetal spaces, and the whole spine is a new spine. There is no decompression from front. There is no decompression from behind. This patient does not need decompression. This patient needs stabilization and arthrodesis of the joints. This is another case. You see, I say that there is no significant compression, but there is a vertical reduction in the height, which gives this called signal. I have written a paper on this subject. You must read that there is a vertical reduction. This is not a one space issue. This is at least 2 or 3 space issue. You see, I have done 3-level stabilization, 3-level facetal stabilization. This is not due to compression, this called signal. This is due to vertical height reduction signal. And this vertical height reduction needs restoration of the height. And this is, you see, beautiful stabilization and beautiful clinical outcome. This is another case. You see ligamentum flavum buckling, ligamentum flavum buckling, ligamentum flavum buckling. There is osteophyte here, osteophyte here, osteophyte. And this is a post-operative. You see new disc formation here, new disc formation here, new disc formation here. And this is multi-level fixation and arthrodesis with facetal spacer. This is a revolution in the field of spine surgery. This is another case. You see there is multi-level disc degeneration, and this is post-operative. There you see the new disc formation. There you see the osteophyte has disappeared. The ligamentum flavum has opened up. This is multi-level stabilization with interfacetal spaces, which I have labeled as Goel facetal spaces, which I will show you. This is another multi-level spinal degeneration. Do not do corpectomy, do not do discoidectomy, do not do laminectomy, do not do laminoplasty. You see there is a new disc which is come. You see this is completely new spinal cord. There is no compression at all in the spinal cord. And you see this is multi-level stabilization, and there is arthrodesis of the whole spine. There is no decompression in the treatment. I also introduced this beautiful revolution. Beautiful revolution. You please see this. Unfortunately, I could not get all the images. You see, there is a disc herniation. The whole world will come and remove this disc from here and remove this disc from here. I introduced this interfacetal spacer, and immediate post-operative, there was a regression of the disc space, of the herniated disc. So this was published. Immediate post-operative reversal of disc herniation following facetal distraction surgery. I introduced in the year 2016 my report of 4 cases. You see, this is the patient and this is the fixation. This is another case. You see, there is a disc herniation, and this is immediate post-operative regression. This cord signal is not due to compression, is due to vertical reduction in height. This concept also I will discuss with you in my subsequent lectures. And this is a fixation in a distracted position. This patient does not need decompression. It needs fixation. So interfacetal intra-articular spaces is a concept, and these are my spacers, and these are my patented, I have patented them in US, and not only the spacers are patented, the technique is also patented. This technique is called as Goel Facet spacer technique, and these spacers are called Goel Facet spacers, and this technique is my patented technique, and this is, you see, devices and methods for treatment of degenerative spine. These are my patents. And also it is patented. There are 23 patents on this subject in India, and this is also FDA approved in India. So these are my spacers. I can give you details of my spacers if you are interested more on these Goel Facet spacers. And this is, we have done very elaborate biomechanical studies, and these biomechanical studies have also been published. So similar concept is also relevant in the lumbar spine. When you see multi-level spinal degeneration, you come and do lumbar laminectomy to do decompression. Some people will come and do discoidectomy at what level, 2 level, and some people will do decompression and fixation. My concept is there is no need for decompression. This is due to vertical instability at the facet. There is no problem with the disc, no problem with the osteophyte, no problem with the ligamentum flavum. It needs distraction, reduction, and fixation by these spacers. So you see multi-level lumbar canal stenosis can be treated by multi-level facetal distraction as a treatment. So we introduced this concept, distraction of facets, for the treatment of lumbar canal stenosis. I must tell you, my dear friends, in my subsequent lectures, I will give you a detailed information about this concept, and I want to show my friends in Morocco and other parts of this region a new revolution in spine surgery. So these facet spacers are very well published. So what has happened is, you know, when we used to kill animals and we used to use the muscles very heavily, these muscles remained strong and there was no spinal degeneration. But now we are concentrating more on our, you know, computer. Our muscles are becoming weak, and our facets are becoming weak, and we are developing this kind of face and this kind of spine, which is a degenerated spine. So this, you know, this concept of distraction is in Indian mythology. You see this lady with the crooked back. This was treated by God by distraction. And similarly, you see these people, there was this treatment in the Greek where they used to treat degenerative spine and deformities in spine by distraction. And this kind of treatment were very popular earlier in the history of spine surgery. So you have to decide for yourself. In my introduction today about the spinal revolution, about the relevance of my hypothesis regarding pathogenesis of degenerative spondylosis and its implication in the facet distraction surgery. Can decompressive laminectomy for degenerative spondylotic lumbar and cervical stenosis become historical? Can anterior surgery become historical? Can discoidectomy become historical? I am saying today, yes. And I will talk to you in more details in my subsequent lectures. Thank you very much, my dear friends. Now, can you introduce me? Can you put my, I cannot see myself. Can you?
Yes, you can unshare your screen.
No, I cannot see my, no, I cannot see my unsharing thing. Can you put my screen back?
I will do it, yes.
Okay. Naji,
Yes, I will.
Yes. Now I want to, you know what? I want to ask my dear friends. I want to ask all the participants, if they little bit agree with this concept, please write yes in the chat box. Yes, there is a chat box here. You say yes. If you do not agree, you say no. I will not mind it. But you write yes or no in the chat box, and I want to see. Can you do that for me, please?
You can do a polls if you want, Professor Atul.
I want you to write in the chat box yes or no.
I will add the
You want
question.
to break?
Everybody. And then I want you to ask questions. But you know what? I will like you, after I will answer your questions after I give more lectures. This is part 1 of my revolution. But I want to give 5 lectures to you and your society. If you allow me, Dr. Hilmani.
Yeah,
I can.
Thank you, thank you, Professor Atul, for this very interesting lecture. And I admit that it's very difficult to understand your concept. I agree with you that stability is very important to assist in spinal in the spine. But I think I prefer to give my opinion at the end of the session. I want to let my friend Professor Bouzouba and Professor Umais
Okay,
and
just
Dr. Jabri to yes.
Yeah, Dr. Hilmani, just I want to make some more points. You know what? This is a new concept.
Yes.
I say this is a revolution. I say this is completely a new revolution. I do not expect all of you to say yes, yes, yes. I know that all of you are doing discoidectomy. All of you are doing laminectomy. Many of you are doing laminoplasty all your life. All your life you are doing discoidectomy and corpectomy. And suddenly somebody comes and say that no, that is wrong. How can you say, yes, I agree? It is very difficult for everybody to say yes. So what I want to do, Dr. Hilmani, I want to now, I don't want anyone to ask me questions. I want to finish my 5 lectures. And when I finish my 5 lectures, I will ask people to ask questions. That is what I want. But few questions, if somebody has, maybe I can answer now. There is a, professor, unmute.
Could you ask for some question, or I do?
I think we will ask questions we will keep one full session for only questions. Now I want you to think about it. I want you to think about the concept. This is a different concept. I want you to please think about it. I don't want you to come to conclusion yes or no. Don't say yes. Don't say no. I want you to think. Tomorrow, in the next lecture, you give me, whenever you are ready, I will come in part 2. I want to give 5 lectures. And the 6th lecture will be only questions. This is what I want, Dr. Hilmani.
Yes.
Can I make
opinion about this? But we have some challenge. You know that we have many speakers waiting for giving their
no problem, no problem.
their
So
topic.
whenever you are free, maybe in the next COVID, after 1 year or 6 months, I have no problem. But if you are interested in this revolution, please call me.
We can discuss this possibility to give you this this opportunity to explain us your concept. It's
Okay, please ask me
For
question.
us, a
Okay.
pleasure. We discuss with our team.
Yes, please ask. Okay.
Professor
Umays,
Mace, you have a
Yeah. Hi. Actually, it's a great talk. I have a few comments. I've used this when I was in the U.S. One thing I realized, although you have to be very careful of this, these are very, very expensive when I was in the US, just to buy this, because you have to do bilateral, basically, cages, and each one was about $1,500 to $2,000. So one thing, actually, and what we used it for, not for distraction, it's more for to enhance fusion. But then I realized one thing, and I can ask Dr. Atul here. There's a few things I may be wrong, but I saw in a few of the pictures that really these sometimes they can create kyphosis. And I see, because we think it's distracting all across, but really what we're doing maybe is you're unbuckling the ligaments from behind, a little bit from posterior disc. And that's why you see that white signal in the disc. But really, I see, if you look before and after the procedure, what you're seeing is sometimes a little bit of kyphosis. And if you look in X-ray, really, especially in the lumbar spine, if you're deviating by a few degrees, you go all the way up, you're going to end up with the patient really being in more kyphotic, especially in the lumbar spine, because I think the disc is very hard to distract. This is my opinion, and I think that's what I've experienced before.
Okay, so you keep this question. Okay, this question, I will answer this question. You see this issue of kyphotic, that it can be kyphotic. I have changed, I will introduce this concept a little bit. You know, I will answer this question in my subsequent lectures. If Dr. Hilmani gives me an opportunity, I will certainly come back. But there is no question of kyphosis. No question. No question. That is just that is just not a correct argument. I have done multi-level fixations, several level fixations. That question, you think about it, there is no question. You see, when you do 4-level corpectomy, if you do 4-level corpectomy or 3-level fixation or 3-level or 4-level laminoplasty, you will develop more kyphosis than this. What we do is we distract the facet and bring it to the normal situation. I see, you know what? We are not over distracting. My spaces are just 2.5 millimeter height. The other thing that I am telling you is that these are, these are patented on my name. And these are, manufactured in some parts of India and some part abroad. But these are not very expensive at all. If you wish, I can give you several free of cost. Don't worry, you think about this concept. Don't worry about the cost. I will give you 100 spaces free of cost if you are ready with the concept. If you are saying, yes.
There question from the floor. How do you make spacer fusion? How do you make it?
You see what, there is a technique which is very well mentioned in my multiple articles. I have given you the articles on your, you can have them on the, you can have the whole, multiple articles have been written by me on the subject as to how to achieve fusion, how to prepare the facetal articulation. You have to introduce an osteotome and then remove the articular cartilage. And then you have to introduce bone chips. You see, the problem is this is a new concept. This is a different concept. You try to understand this concept. If you wish, I can give you, I have told you I will give 5 lectures. So why you want to hear the same, same old thing of same tumor, same thing? You listen to a new revolution. I want to change the entire concept of your, I promise, completely I will change you. This is a word I'm giving you.
Okay.
Jaber, there are some questions from the chat. Give you 2. Is it the same concept of interspinous process spacer? And the second one, the concept will address the cord compression But how about the loss of lordosis?
You see, anterior spinal spacers are also the same concept, but you know, to that what the concept in anterior spine surgery is to remove the disc, to remove the osteophyte, to do decompression. That is the concept. And spacer is done basically for fusion and some distraction maybe. But here what I'm doing is I'm not doing any decompression. I'm doing just distraction. I'm doing just stabilization. And this is a magic treatment.
There are
The
questions
other
from
other
Ahmed
thing
Al-Khan.
was
Question, what
Question
about the loss of lordosis?
Al-Khan.
loss of lordosis is, you know, when you do 2-level fixation, 3-level fixation, the lordosis will automatically disappear. What is important is stabilization. What is important is the recovery of symptoms. If you do 3-level fixation, the lordosis will go. If you do 4-level, you see, I have done 5 levels facetal stabilization, the lordosis certainly reduces. But it is not the lordosis, it is the power in the hands, the strength in the fingers, strength walking. That is more important. Ultimately, we are going to result in arthrodesis. Fusion is the ultimate aim, is not distraction, is not the aim of surgery. Aim of surgery is ultimate fusion.
There are question from Ahmed Al-Khani. Ahmed Al-Khani.
Did you enjoy, Dr. Hilmani, did you enjoy the concept? Whether you agree or not, that is different, but you enjoyed it or not?
Hello?
I agree with you. I am very interested by this concept, but we must some time. Yeah, we must some time to understand the concept, because our brain is, I don't like to say formatted, but we have some concept. Is we can't change our brain immediately when we learn, when we see your concept. It's very difficult to admit. If we, without the compression we have, I agree with you that when we show us imagine postoperative imagine, it's beauty, but what about the clinical improvement? It's very important. There is any improvement or no?
You see my improvement, you must read my articles, 100% improvement, 100%, not 99%, 100% improvement. And you will read several of my articles, you read my results are all mentioned. Unfortunately, you know, my patients do not speak Arabic, or, you know, I cannot bring them, but I can make them next time. You see, I have prepared for 5 lectures. So if my revolution does not finish in 1 lecture, Dr. Ilmani, if you give me an opportunity, I am ready to give 5 lectures. If you are busy, if you have another fixed program, then of course, then that is your issue.
Professor Khan.
There are some questions from the floor. Please.
Can I ask my question, please?
Yes, Professor Khan.
Yes.
Okay, well, good evening, everyone. Thank you very much, Dr. Atul, for the presentation. It's really very highly done, and with a major concept of pre-understanding the degenerative disc disease. I want to agree with the previous comments about the issue of going from the back to distract, and what we see is a bit more of chaotic changes. Nevertheless, as you just elaborated later, you are talking about fusion. If you obtain this fusion by anterior discectomy, cage and plate, if you are going from the back with lateral mass screw and osteophyte formation for fusion, or going from the facet, the end result is the same. You are reaching into fusion of this segment. So you are not preserving motion, you are not preserving anything, modifying your procedure in a way to reach the goal of fusion. So the issue of distracting, I want you to elaborate more on about removal of the buckling of the posterior longitudinal ligament. Is this related to the distraction, or as we all see, osteophyte formation stopped and even regressed after anterior decompression or after posterior stabilization with lateral mass screws only? Is it only another model of fusion, or there is a point behind it other than this? Thank you.
See, it is, when you do anterior surgery, basically the purpose of anterior surgery is decompression. Like you remove the disc, you remove the osteophyte, you remove the bone, and then do fixation under distracted conditions. The basic aim is like you do corpectomy. You do corpectomy for what? It's for decompression. So the basic aim of that operation is decompression. My basic aim is not decompression. My basic aim is fixation. My basic aim is stabilization. Now that stabilization can be done by only posterior fixation without laminectomy. That is also a good option, and that also will reduce the osteophyte formation. And that is also published by me. You must read my articles on this subject. There are several articles of mine where I show that posterior fixation will result in reduction in osteophytes. So essentially what I'm saying is there is no need for decompression, which the whole world is doing. You must agree to it. You should not say, no, I don't agree. You should say, yes, I agree. Don't you? The whole world is doing decompression. Laminectomy or laminoplasty, even if you are doing lateral mass fixation, you will do laminectomy. Even if you are doing distraction fixation from front, you are doing discectomy, and decompression is the aim of the treatment. I am saying finally, this is a revolution, and this is a complete revolution. You please try to understand. You please try to change little bit, think about it. I know it is difficult for you to think and suddenly say, yeah, I agree. How you can agree? Whole life you are doing decompression and suddenly you cannot agree. I understand. But I have presented to you many cases, and I have presented to you many publications. This is all in the top journals of the world, which I have presented. So this is a technique which is not in my mind. It is in the journals. You please read the journals. You please try to understand my concept. And please, if possible, agree with me.
There are other questions from the participant. There are three. Aran Agrawal. Aran Agrawal. Aran Agrawal. There are questions
Yeah.
from Abdullah Salim.
I have seen Professor Goel operate, and I have seen hundreds of cases of his, and without any bias, I have seen the results also. And I may not be, we cannot explain how it is happening, but the results are 100%. And I've seen that, and that's why we have to give it a thought, and we have to practice and try to follow things which are happening correctly. Maybe we do not know much more than what we know, what we should know. That's
I
all.
agree with you. You think about it. Yeah, I agree.
Okay.
Thank you.
Abdullah Salim. Abdullah Salim. Please, Abdullah Salim.
Hello. Yes, I'm Dr. Abdullah Salim, consultant neurosurgeon from Libya. Thanks for letting me attend the meeting. I'm very interested in this subject, really. As neurosurgeon, when we see a decompression in the MRI, when we see a cord compression in the MRI, our immediate goal is to make a decompression, either anterior discectomy, corbectomy, or posterior laminectomy and fixation, whatever. But having the risk of injuring the dura and some neurological deficits, yes, fleek, others. But having this method or new concept will make the neurological deficits less likely, because we are not reaching into the dura, actually. Yes, it's a new concept. It's very difficult to understand and to have this concept running our
So
practice.
Abdullah, so
Yeah.
when you do next spine, you remember me, okay? You
Yes,
remember me?
yes. Still, I have to finish. Sorry. Before we used the DIAM system, that's interspinous spacer. We used
Yeah.
it in the lumbar spine, that's silicone
Yes,
or
yes.
titanium made, but it really failed to give a symptomatic relief for the patient. In the next few months, we have to remove this interspinous spacer, and we put some screws and decompress the spine again. But with these techniques, I don't know how it comes to our
See, you must,
practice.
Abdullah,
Another thing. Yes, another thing. This loss of lordosis really is a big problem, especially in the lumbar spine. If we have to make several levels, do you come in mind how patient can run whole life with his spine in loss of lordosis or in a kyphotic form? Or there's any long-term study about your cases?
yeah, there is long. I described this technique in 2010. Means there is already 10 years of follow-up. And I had told you earlier that I will clarify all these issues which you are raising in my subsequent lectures. I will qualify. I will explain to you what issue. This is just an introduction. What today I gave you introduction. I mentioned to you, and I will clarify all these issues as this is part one of my revolution. And I have told Dr. Hilmani I want to give 5, but he says it is not possible. So I will be somehow, you have to come to meet me in my own country to get the rest of the 4 lectures.
I hope that we can finish the whole 5 lectures.
I hope. I also want to give.
Next question is from Pattern Safari. Pattern Safari.
Yes, I'm here.
Yeah.
Please, can I ask my question?
Yes.
Okay, thank you for Professor Atul. This is the big revolution in the spine surgery. I'm from the Democratic Republic of Congo, from Africa. So I have a few questions. The first is to know if you treat the huge disc herniation with this technique without doing discectomy. If you have a huge disc herniation, do you do discectomy or not? The second question, if you have a spondylolisthesis, do you use the same technique, or you have to do arthrodesis with screws without putting facet joint? Facet joint. I don't know how you call it.
Yes.
But,
No. I understand.
Yes.
So I will. You know what?
Yes. Please.
How to treat? You see, how to treat in spine? There are various issues. One is how to treat disc herniation, how to treat lumbar canal stenosis, how to treat cervical canal stenosis, how to treat multi-level degeneration, how to treat single-level disc degeneration, how to treat radiculopathy, how to treat myelopathy, how to treat OPLL. OPLL is a big issue. How to treat spinal cervical kyphosis, how to treat dorsal spinoscoliosis, kyphoscoliosis, how to treat lumbar spinal scoliosis. There are various issues. How to treat radiculopathy. So if you give me opportunity, I will discuss these things. I cannot give answer in one question, in one line. But if you are interested, these are all published. My how to treat a disc that you ask me a question, you please read my papers. And how to treat lumbar lumbar degeneration. I have to also tell you, I have treated one, I don't want to name, but very many people from Africa with scoliosis, lumbar scoliosis. So I will want to give all these things, if you want me to answer in one sentence, I will say yes, I will do without discordectomy. I will do yes. But you will like to ask me how, why, what will happen. So that all those things, you please leave that for subsequent lectures. How to treat OPLL. Will you answer this question, or can I answer in one question? It is not possible, but I want to give a full lecture on OPLL. There is so much confusion about OPLL in the whole literature. How many people do OPLL by corpectomy? How many people do laminoplasty for OPLL? I am saying this is not the correct form of treatment of OPLL. You should not do laminectomy. You should not do laminoplasty. You should not do corpectomy. This is my concept, and I want to introduce this concept to you.
Okay.
Other
Just
from?
a last question, please. Please.
Yeah.
Professor Atun.
I have other question, please, pattern.
Yes, yes.
A question from Fouad Ben Kad. Fouad Ben Qaddous. Fouad Ben Qaddous? No, no question.
Mohammed Majati.
Go. Yes.
Dr. Bouzouba, there is a question from Dr. Majati.
Yes, please, Majati. Dr. Majati.
Oui, thank you, Professor Bouzouba. Thank you, Professor Atul, for this nice presentation and new revelation about myelopathy surgery. My question is about dynamic movement and sagittal balance of the spine after surgery.
You see, the concept is very clear. The concept is that instability is the issue and stabilization is the treatment. That is the concept. Finish. Now, if there is a segmental issue, you stabilize. One segment is not working properly, you don't start removing the bones and don't start removing the ligaments and don't start removing the disc and osteophyte. You stabilize. Instability is the issue and stabilization is the treatment. That is my concept.
I have a question, Professor Atul. It's in your concept, you speak about vertical instability. Yeah. Yes. How can we how can you demonstrate this vertical instability?
There is no demonstration possible.
It's right or other ways.
You cannot see the vertical instability. You do dynamic flexion extension images, there will be no instability. So imaging, the radiology, the MRI, the CT scan will not show you instability. But when you see the osteophyte, when you see the ligamentum flavum bulging, when you have radicular symptoms, when you have myelopathy, it means the spine is unstable. And it means stabilization has to be done. There will be no instability. So imaging, the radiology, the MRI, the CT scan.
حافظ جمل حافظ.
Can I have a question, Professor Helmani?
Yes, Ustad Wafa.
I would like to thank you, Professor Goel, for this fantastic lecture. Very good. Enjoyed this very much. But I have a question maybe out of the box. Does this instability has any relation to the modic changes?
Dr. Wafa, I don't understand this modic changes. I don't know what is this. I am a very simple man, very simple. My concepts are also very simple. This modic changes, this sagittal balance, all these things are very complex issues. And there is all arbitrary issues. and you go on discussing sagittal balance, this balance, that balance, you will never get an answer. Your patient wants to be relieved of his symptoms. Your patient wants to be relieved of his myelopathy, of his radiculopathy, of his tingling paresthesia, of his pain. He is not bothered about his sagittal balance or these modic changes. You understand? I don't know what is modic change, but
yes. I have a little question also. How long does it take clinically to get improvement, say, in subaxial cervical, these cases you have showed in subaxial cervical degenerative changes?
If you ask me this question, you must say, I will believe you. The improvement will be in the immediate postoperative period in the evening of operation. My promise. And also, I am telling you, you see, of course, you want to, many of the people in Morocco and all want to go to all the time to America and America, America and America. But why don't you change your direction towards India sometime? Come to Mumbai and I will show you what nobody else will show you. You come. Never all the time.
I will do my best, and probably.
And you know, it is very simple to come to Mumbai. It is much cheaper.
Maybe after coronavirus is over.
Yeah.
Probably we can invite you to Cairo.
Yeah, I will come to Cairo. Cairo is my, you must see, I have many students in Egypt, many students, and some of your students are very fantastic students in Egypt and who know my technique. I know one boy, Ahmed, I don't know his second name, but Ahmed was with me for 3 or 4 months. There were many young people from Egypt who know my concepts.
Yes, of course we know your concept. So I will do my best to come over to Mumbai, and very soon I will send you an invitation to Cairo. Thank you.
Thank you, thank you, thank you very much.
I may ask Saeed Hilmani, if there is no question, I have an announcement.
About what? Yes.
Can I give my announcement?
Yes, you can, but
as some of you know, I am a member of WFNS Education Committee, and I am in charge to give a talk on how to avoid a wrong level in spine surgery. I have to give a talk later. For that, I send to all of you a question sheet, and I beg you to answer me, please, for that. By the next week, you will receive an email, and please answer me on my question sheet.
Okay. Thank you, Dr. Bouzouba. Thank you, Professor Umais, and all of participants. I would like to thank our best speaker, Professor Atul, for this very, very nice and very controversial topic. I agree with you that it's maybe will be the revolution in spine surgery, and I promise you to discuss this to give you the opportunity to continue your topic, and you will receive the response shortly, inshallah, with our Moroccan and Arab Spine Society in our team and committee. If there is no questions, Dr. Mehdi?
Yes.
There is no questions?
There is some question that there's a lot of questions. We can do it later.
Yes, but if there is interest,
I don't know Professor Ahmed Fawarha from Professor Fawarha from Jordan.
Fawarha.
Is
there is.
أهلا دكتور حلماني.
أهلا وسهلا. How are you?
I am doing good. It was very nice talk actually. It's a nice concept.
You have a comment for this lecture and or question for Professor Atul?
Well, I think he has a fair request to continue his talk. We can listen if the other people agree to listen to his all 5 talks, then we can discuss. This is really new concept. Though there was screws introduced, facet screws, there was introduced percutaneously. I think they have the same concept.
Okay, thank you, Professor Fawaha. It's a pleasure for us to have you as a participant in this webinar. Dr. Sghir,
Yes, yes, Professor Hamani.
you have a word to give this
Thank you for all for Professor Atul for this very good lecture and the new concepts. Just a little question, finally question. How many years do you think, Professor Atul, the new concepts or the new concepts for you have to be accepted? How many years you think about by all the community, international community of neurosurgery?
No, you know, I hope it will be accepted. Not, you know, I hope soon. I hope. Okay. And I want, you know, I conduct many workshops here in India. I do regular, you know, teaching programs, not for spine, but cavernous sinus and skull-based surgery, basically. But now I was planning one spine workshop, but because of this corona, I had to cancel it. As soon as this corona disappears, I will do this workshop, and I wish that many of you can come and we will have a nice time. And I want to show you, and you don't get convinced unless you see with your eyes. You don't get convinced. That is my request for you. Don't get convinced. But if you want, if you are having doubts, you please come and we will enjoy nice Indian dinner and nice, fantastic cases.
Okay. Thank you, Professor Atul. Thank you, Professor Bouzoba and Dr. Mahdi and Professor Al Hamani and all for the participants in this webinar. And Professor Bouzoba, you can. Professor Bouzoba, you are in.
Thank you, Dr. Sghir. Professor Umais, Ibrahim Umais.
Yes.
Still with us, Professor Umais? So, Mahdi.
Professor Umais is not with us.
Mahdi, Mahdi, you must open the microphone.
Yes, yes.
Ibrahim Umais with
no, it's not there.
Okay, Professor Atul.
Yeah, yes.
For making this this webinar conversation or this topic very interesting, I think that we will be with debate with other between conventional and revolutionary philosophy for spinal surgery. I think that will be better and interesting. How you think?
Very good, very good. That will be interesting.
Okay,
but you know what, Dr. Hilmani, the whole world will be on one side and Atul Goel will be on one side. So you are giving me the balance, sagittal balance is not there.
No, you defined your concept, and because in the literature there is many conventional concepts in spine surgery. There is a revolution, and to be very interesting and give us a lot of information and to introduce their technique in many countries. I think that we need a lot of interesting and understanding this concept. I think.
Professor Atul, thank you very much for your outstanding talk. Really, this concept is really interesting, even if perhaps don't agree with this, but not fully. We will attend the next part of your presentation, and I am sure that we will have fruitful discussion later.
Thank you very much.
Thank you.
And I really enjoyed my presentation.
Yes.
And I wish that you please think about it, and inshallah we'll meet in India. Bye-bye. Bye-bye to all of you. Bye-bye.
Thank you very much. Thank you.
And see you soon, inshallah.
Yes.
See you soon.
Thank you,
Bye-bye.
Mr.
Bye-bye.
Atul. Thank you.
Thank you, all of you, and thank you to all participants. Thank you.
Thank you very much.
Thank you.
Mehdi.
Oui.
بارك الله عليك.
Merci beaucoup. Barakallahu fikum.
Si Mehdi,
à la prochaine.
Si Mehdi, merci beaucoup. Hein.
Barakallahu fik. Merci beaucoup.
Oui.